All right, so what we're doing is cardiac output, and the reason we're doing this is because once we get cardiac output, you'll be able to do cardiac drugs. The other reason we're doing this is because you'll have to reproduce this on the test. The philosophy on this, or the teaching pedagogy is, I think it's hard to memorize it unless you understand it, but if you understand it, it's pretty easy to memorize it and reproduce it. So there's two reasons we're doing this. One, you have to reproduce this chart. Two, there's going to be some valuable information in order to do the cardiac drugs question as well. So the first thing is, I always put this at the bottom, I'm not really sure why, but cardiac output, which I often abbreviate CO, is expressed in milliliters per minute or liters per minute. So it's how much blood is pumped per minute. So usually liters per minute. And it's the product of two things. It's the product of heart rate, which is expressed in beats per minute, times stroke volume, which is expressed in milliliters or liters per beat. So heart rate is essentially how many beats per minute. That one's pretty obvious. Stroke volume is just a term for any pump. It's how many milliliters of fluid are moved per cycle of that pump. In the case of the heart, that's obviously how many milliliters are pumped every beat of the heart. Typically, heart rate is 70 beats per minute. And a typical stroke volume is 60 to 70 milliliters per beat. We'll go with 70 milliliters per beat. So the beats cancel out, and we end up with either 4,900 milliliters per beat or 4.9 liters per beat. So you pump about 5 liters of blood per minute. The interesting thing about that is that's about how much blood you have. So you pump the entirety of your blood around in roughly a minute. Where we're going with this, though, is we want to talk about what goes into this control of heart rate. And your heart rate is mainly controlled by the autonomic nervous system. And remember, the autonomic nervous system has two branches. It has the parasympathetic, which is rest and digest. And this will decrease heart rate. So the vagus nerve is the major player. It's a parasympathetic nerve. And that decreases your heart rate. The part of the autonomic nervous system that speeds up heart rate is the sympathetic. And we sometimes call this the fight or flight. And this will increase heart rate. There's some other things that will contribute to this, like fear, adrenaline, thyroxine, which is a metabolism hormone from the thyroid. And then there's one specific one that I'd like you to know, and that is something called the Bainbridge Reflex. The Bainbridge Reflex is there are stretch receptors in the atria that will speed up heart rate. Trying to keep plenty of room over here. Stretch receptors in atria that increase heart rate. So it's nice that the heart has a way of saying, I'm seeing a lot of blood here. I need to get this blood moving, so let's increase the heart rate. you'll see that there's something else over here, that when the atria and the ventricles see a lot of blood, they'll also increase their contractility. The cool thing about that, and it allows heart transplants, is the heart basically knows what to do when it needs to do it. So you don't need the brain telling the heart, hey, I'm exercising now, let's speed up the pace here. The heart knows because if it senses stretch in the atria, there's a feedback reflex that increases heart rates. There's also a feedback reflex that says to the heart, contract harder. So that's the easy part, heart rates. The more challenging ones over here are preload, contractility, and afterload. We're going to write underneath these, so when I draw my arrows, I'm going to kind of leave some space. And this will seem kind of complex until you get where I'm going with this. But if I write something above the word, it means it increases preload, contractility, or afterload. If I write something below, it means it decreases. Which, at least for preload and contractility, are going to be fairly straightforward. But for afterload, it gets a little complex. As if I use green, it's going to increase cardiac outputs. If I use red, it means it's going to decrease cardiac output. So you can have increases and decreases in preload, increases and decreases in contractility, increases and decreases in afterload, and they can have different effects. So just as a heads up, an increase in preload will increase cardiac output. An increase in contractility will increase cardiac output. But an increase in afterload will decrease cardiac output. So that's why we're doing the color coding. First of all, what preload is the more the heart is filled, the stronger it contracts. If we're talking about skeletal muscle has two speeds. It's either on or it's off. Cardiac muscle has different gradations, so it can contract harder or softer. One of the things about cardiac muscle too is the more it's initially stretched out, the harder it will contract. Sometimes more information is helpful, and the way it works, or the way it's thought to work, is you remember troponin is a calcium binding site, and it pulls tropomyosin out of the way, and it causes actin and myosin to basically slide along each other. The idea is that the calcium binding site on troponin stretches as the cardiac muscle stretches. So as the cardiac muscle stretches, that calcium binding site gets bigger, so it's easier for calcium to bind. And if it's easier for calcium to bind, then you'll be able to contract that muscle better. What it means functionally is if the heart sees more blood, it's going to contract harder. That's nice, because again, that means the heart can kind of control things on its own. So up here, if the heart is stretched, heart rate goes up. Because of preload, if the heart muscle is stretched, it contracts harder. Some examples that might make this more clear are when you exercise, your heart sees more blood. The way you move blood up through your veins, we'll talk about this when we get to blood vessels. The way you move blood up through your veins is skeletal muscle contracts around those veins. So when I'm walking like this, my skeletal muscles are contracting around my veins and squeezing them. And so it squeezes the blood up through my veins, kind of like you're squeezing toothpaste out of a toothpaste tube. So if all of a sudden I start running in place, then my skeletal muscle is going to start contracting more, and it's going to start pushing more blood up to my heart. Which means my heart is going to fill more, and when my heart sees that extra filling, it's going to contract harder. Similarly, if I have a slow heart rate, so we're talking Lance Armstrong, 35, 40 beats per minute, it's probably lower than that. The heart has more time to fill, so it contracts harder. So someone like Lance Armstrong, you would have a low beats per minute, But that heart would fill and fill and fill, so the preload would keep going up, and then it would contract very strongly. So it's kind of a balancing effect. And by balancing, I mean if you have a rapid heart rate, your heart is beating really quickly, but it's not having enough time to fill, so the preload goes down, so it's contracting weakly at least. It's not contracting as hard. Another kind of nice thing is if you're hemorrhaging or you have blood loss, you don't have as much blood to fill the heart, so preload goes down. The heart won't contract as hard, so you won't be pumping blood out faster to feed that hemorrhaging. So preload is essentially the more blood that you stuff into the heart, the harder it will contract. We could put preload actually as a subheading of contractility, but you'll see the word preload a lot, so it's important to kind of keep that separate. Because what contractility is the heart contracts at different strengths. So again, back to skeletal muscle. If you pull out an individual skeletal muscle fiber, it's either on or it's off. Cardiac muscle can turn up to a 2, can turn up to a 5, can contract to a 10. It can work at different strengths, which means it can be manipulated. Some of the things that manipulate it are, if you have increased blood calcium, then you have more calcium to cause this cardiac muscle to contract, and so the heart will contract harder. You can stimulate calcium channels with certain drugs, pharmaceuticals, so you can give drugs to increase the contractility of the heart. The sympathetic nervous system, specifically adrenaline, can increase the contractility of the heart. What adrenaline does is it stimulates potassium channels. And maybe I can squeeze it in here. But remember when we talked about cardiac action potentials, that potassium is leaving as calcium is coming in. So if you can stimulate that potassium channel, we're talking about in the plateau phase of the cardiac action potential, calcium is coming in as potassium is leaving, and those two are linked. So if you stimulate potassium, you stimulate calcium entries, so that's how adrenaline generally works. Things that decrease contractility are things like increased potassium. Now this one's tricky, but what's happening here is going to be important because this process occurs in other areas of the heart too. So what I'm going to draw, again, is kind of like what I drew up there, but I have more space down here. So if we have potassium on the inside of the cell and some on the outside, remember that during the plateau right here, potassium is leaving and calcium is entering. So this calcium coming in is dependent on this potassium wanting to leave. But if all of a sudden you have increased potassium, the 850 bananas, to be honest, you probably couldn't do it with diet, but if you're having renal failure and you're not getting rid of potassium, or if there's an IV error and you have too much potassium, now you have all this extra potassium out here. This potassium says, I don't want to diffuse anymore. There's already lots of potassium out there. Usually I leave because there's no potassium out there, but since there's lots of potassium out there, I don't want to leave now. So that means this potassium doesn't want to leave, which means this calcium can't enter. One of the reasons I really go into electrolytes and action potentials is because when we get to the kidneys, you'll realize you'll be able to come back to those action potentials and see, I hope, that wow, if there's a potassium imbalance or there's a calcium imbalance, the kidneys are messing up, or there's a sodium imbalance, it's going to throw off action potentials in the heart. So if the kidneys are failing, it's going to damage the heart, or it's going to alter the function of the heart. If you have a potassium imbalance, it will throw off your calcium's ability to go into the heart, and it will affect your contractility, your heart strength. Similarly, if you have an increase in acid in your body, so acidosis, again, we're trying to fill this one out here because we're talking about the heart, but some of this will make more sense when we get to the kidneys. Acidosis would also decrease contractility. So if somebody's in a situation where their blood is acidic, we'll talk about this with respiratory, or Greg will talk about this with respiratory. Maybe you're not getting rid of CO2, and so you're getting acidosis. That would also decrease the contractility of your heart. Without going into, I don't want to go into a lot of details on this yet until we talk about electrolytes, but the reason this is because essentially in the body, if you have an increase in hydrogen, it equals an increase in potassium. So acidosis would throw off your potassium. That potassium increase would make the potassium inside the cardiac cell not want to leave. If the potassium won't leave the cardiac cell, then calcium cannot come in. If calcium cannot come in, then the heart won't contract. The last one here is calcium channel blockers. So those are the things that affect contractility. Afterload is really the tricky one, because you just have to think it through a little bit. What afterload is the more resistance the heart has to pump against, must pump against, the slower the contraction. Slow contraction equals less blood pumped. And since we're talking about stroke volume, that makes sense. If the heart cannot pump as much blood, then the stroke volume is going to be decreased. The reason this is any muscle, the speed of contraction will depend on the load that it's against. So if you have a 5-pound barbell in your hands, you can lift that really easy because the load is not very great. You can contract really, really quickly if you have a 5-pound barbell. If you go up to a 25-pound barbell, I will still be able to lift a 25-pound barbell, but it would be slower. Maybe even a 50-pound barbell. No, I'm kidding. I'm lying about that. Maybe 40. But I could lift a 40-pound barbell, and I would do it really, really slowly. If muscle does not have much load, it can contract really quickly. If muscle has a big load, it contracts more slowly. Now, in the case of the heart, obviously we're not talking about barbells. We're talking about when this heart goes to contract, what is it? What resistance is it up against? Is there a lot of blood out here already? Blood pressure's high out here. Is the aortic semilunar kind of sticky? It's got stenosis. Are the arteries narrowed? So now we're trying to pump blood through these narrow tubes, not these nice big elastic tubes. So the heart goes to contract and it says, I've got a lot of resistance out there, so it slows down its contraction. So if you have thick blood, or you have stenosis of vessels, or you have high blood pressure, when the heart goes to contract, it's like trying to lift that 25-pound barbell. It can't do it very quickly. So it goes to contract, and it's got to start all over. It goes to contract, and it has to start all over. The thing about if you're in a gym and you're lifting 25-pound barbells, it's just going to take you longer to do 10 reps than it would to do 10 reps on a 5-pound barbell, because I control how fast I'm contracting. But the heart doesn't get to do that. Somebody else is telling it when to start over, so it starts to contract, oh, we've got to start all over. Starts to contract, oh, have to start all over. So the problem with afterload is, if I'm contracting slowly, I'm not going to be able to push out all the blood, which means I'm not going to be able to pump as much blood, which means my stroke volume is going to go down. If you have nice thin blood, then the heart's like, ooh, that is really easy, and it can squeeze out 70 milliliters every time, so my stroke volume is going to be fine. But as soon as you introduce an afterload or some resistance, the heart starts to contract and can't contract all the way. So maybe some examples, and now we're switching our colors because we're talking about increasing afterload, but it's going to decrease cardiac outputs, are an increase in blood pressure will increase our afterload. Stenosis of vessels, so hardening of vessels or even valves and vessels. Stenosis is hardening, and if a vessel is hardened, it can't stretch and accept this blood that's coming into it, which means you can't pump as much blood to it, which means there's a resistance. Or if you have thick blood, things that decrease afterload are essentially anything that decreases blood pressure. Alright, so the two reasons we're doing this is because you have to reproduce this on the test. There's some wiggle room, to be honest. It doesn't necessarily have to be perfect, but the majority of it has to be there. And again, I think it's hard to memorize unless you really, really can think through it and understand it. The other reason is so many cardiac drugs take advantage of if you can just change blood pressure, then you can change afterload, then you'll change stroke volume, and then you'll change cardiac outputs. So a lot of drugs, somehow or another, they just reduce blood pressure. I'm going to write it this way, but I'm going to be cautious. I don't really want you to write it this way on the test, but just for the sake of teaching it, it's a little easier to just point out that all of these drugs, what they do is they decrease blood pressure first, because if you can decrease blood pressure, you're going to decrease afterload. And if you decrease afterload, you will increase your stroke volume. And if you increase your stroke volume, you will increase your cardiac output. So we can put that in kind of a nice little box. And we can point out that a lot of the other drugs that are on that sheet, does anyone have the cardiac drug sheet? So we're looking at this sheet. You'll notice that these guys over here are your chronotropic and your inotropic. And to get those down, you have to understand the cardiac action potential. So you have to understand the autorhythmic action potential and the cardiac muscle action potential. And to get that, I would look at the beta blocker notes or the beta blocker video on YouTube. You notice there's all these other drugs over here that are afterload drugs. Somehow or another, they reduce blood pressure. So if you look across here, we've got thin blood, reduced fluid, reduced vessel tension, anti-hyperlipidemics. And I want to be cautious about this. I put this together a long time ago, and I put DGH draft right across it because I want to be clear that DJ's a PhD, and he giggles when he hears PhD. I'm certainly no MD, but I'm trying to organize all of this so that you can understand it. So I wouldn't say that this is clinical quality information. I did feel better, though, when I looked at American Heart Association. If you look up American Heart Association, they have a chart that's called Cardiac Drugs at a Glance. And I would say that it's fairly similar to this. It goes into anticoagulants, anti-hyperlipidemics. It goes into ACE inhibitors, vessel relaxers, and things like that. So use this, or maybe go to the American Heart Association, or just Google cardiac drugs at a glance and you'll find that. At that point, what you'll realize is things like diuretics reduce fluid. And if you reduce fluid, that will decrease blood pressure, decrease afterload, increase stroke volume, and increase cardiac output. If you give an ACE inhibitor, this will make more sense once we get through the urinary system, but this reduces sodium and relaxes, let's say, dilates blood vessels. So if you reduce sodium and dilate blood vessels, you're going to reduce blood pressure. Reducing blood pressure will reduce afterload. If you reduce afterload, you'll increase your stroke volume, and if you increase your stroke volume, you'll increase your cardiac output. So in my mind, AMP2 is all about seeing sequences, so here's where I caution you. I wouldn't really memorize this as down, down, up, up. I wouldn't try and memorize these things and just remember, well, all I gotta do is put these 4 things down and down, up, up. Because one of the things is you're gonna do this multiple times on the test. So you're gonna have ACE inhibitors, you're gonna have diuretics, you're gonna have adrenergic inhibitors. Dilates vessels. You're gonna have lots of answers like this, and if you don't have this box down pat, and you make a mistake, then all of your cardiac drugs are gonna be having error in them. And the thing about the way I think I'm trying to test you is you're making yourself a textbook here. There's no way that you should have this out of sequence, because you should flip back to your cardiac output chart and say it goes BP to afterload to stroke volume to cardiac output. So I'm not trying to come down on you, I'm just trying to make sure. Sometimes shortcuts are fraught with errors, and they'll create problems when you're in the stress of the test. So what I'm trying to encourage you is to really see how this sequence works. If I decrease blood pressure, I go from a heart that's like this to a heart that's this. So I've decreased my afterload. And if I go from a heart that's this to this, I can pump more blood, which means I've increased my stroke volume. And I know the cardiac output is heart rate times stroke volume, so if my stroke volume goes up, then my cardiac output goes up. Statins. Reduce fat in blood. Blood flows more smoothly. That reduces your blood pressure, reduces your afterload, increases your stroke volume, and increases your cardiac output. When you put this on a test, I think it's important to see sequences, and I think a little bit of repetition is good. So I would rather you not, in fact don't, please don't, put a box like this and do it like I'm doing. It just helps me to create space. Write this sequence of events. Write adrenergic inhibitors dilate vessels. That reduces blood pressure, that reduces, you can use arrows and you can use shorthand, but write this whole sequence right here. And then for this drug, again, write this whole sequence. Repetition is good. Write this whole sequence again. Write them all as separate drugs, please. One other asterisk one I want to give, because everyone's heard of them. And I just want to be careful. Because you've heard of blood thinners, you've heard of Coumadin and warfarin, which are the same drug. You've heard of heparin, and you've heard of aspirin, how aspirin thins the blood. And so you're tempted to say, well, blood thinners, blood flows more smoothly. So this decreases blood pressure, decreases afterload, increases stroke volume, increases cardiac output. And I will say, to be honest, for our class, I would accept that answer. As long as we put an asterisk next to it. Because it's logical if you accept that these things actually thin your blood. But Coumadin doesn't actually thin your blood inside of your vessel. If you start to bleed, it won't clot. And so you have this perception that blood is thin. But your blood doesn't flow any different with Coumadin. It just means that if you have a small nick in a blood vessel, you won't get a clot there. Or in the case of aspirin, platelets won't accumulate there. When we get to blood clotting, you'll realize there is a difference between heparin, Coumadin, and aspirin. They all affect blood clotting from different angles. So they are technically 3 different types of blood thinners. But do know that technically blood thinners do not affect afterload. They generally don't affect blood pressure. It's not a blood pressure treatment strategy. And so it's not absolutely accurate that blood thinners. But I wouldn't count it wrong, because if they really did thin the blood, then that is logical that blood would flow more smoothly, and you would go through the sequence. Mr. Al-Faqih, how are you thinking? What are you thinking?
I'm fine.
Hopefully at this point you're like, I'm kind of getting this cardiac drugs thing. If I just sit down for a couple of hours and start looking at them, I would say the first place you look is cardiac drugs at a glance from the American Heart Association. Read through that, and it's going to take digging, because if you see that something is affecting heart rate, you have to figure out which ion channel is being affected. But I wanted to get this done today, so that now we have a week and a half before you actually have to answer this question. So as soon as you have some stuff, you're like, I think I'm getting there, you can email me, and I will check it, and we'll go from there.